All right. Welcome everybody to December's Home Birth Cafe. And we have Golden Chiropractics, right? Michaela and Goldie with us. And we're just going to go ahead and get started right in here. I will put in the chat my website, and feel welcome, Goldie and Michaela, if you want to put anything in there. And yes, I'm excited. There's some things that I don't know much about Weber technique, and so I'm gonna let you guys take it away, and I will switch you guys so then you can be the host. And there you
go. Oh, thank you, Margaret, for inviting us to speak tonight. I'm Dr. Goldie, and this is Dr. Michaela, and we are chiropractors at Golden Chiropractic.
In Aptos.
Our office is in Aptos. And we have a specialty and a special interest in working with pregnant patients and postpartum patients, and Dr. Michaela sees infants, and so it's so fun to, just share information with your audience about the work that we're doing. So anything you want to add, Michaela, before we dive in?
I think that about covers it.
Okay, great. I put our website in the chat. goldenchiro.net is our website, and you can look for resources there in our blog. We have lots of blogs on working with pregnant women, as well as a scheduling link for anybody who is interested in booking an appointment.
Oh, wait, hold on. Just if any questions come up as you're viewing this recording, I'm going to type in our office email address, and you can shoot questions for us over to that email, and we'll reply to you there. Let me just add that really quick. Is it info@golden?
Yeah.
Chiro.net?
Mm-hmm.
Yeah. Okay, perfect.
Yep. So the email address is info@goldenchiro.net.
Awesome. Thank you.
All right, so let's see if we can share our screen. We're going to go to...
I think it should be desktop one, and then we just go to the tab.
I want to pick the... Desktop is going to show the whole thing, right? Well, that one's not showing up, but let's try this one.
There we go.
Okay. I think you're seeing my entire desktop, but that is okay. So let me just move some things around. Ignore all the photos in my background. Okay, so today's topic is optimal fetal positioning. And you take it away, Dr. Michaela.
So the purpose of this presentation is to go over anatomy of the pelvis. We're going to be discussing the different ways that baby could be presenting in utero and what that means. We're going to be talking about what that actual optimal fetal position is, and then how we can achieve that if that's not the way that baby is currently presenting via Webster technique, which is a specific chiropractic technique for pregnancy and balancing the pelvis. And we're going to dive into how balancing the pelvis can affect the baby's position in utero. All right, so this is a diagram of the bony pelvis. So we have our hip bones at the sides that connect to the sacrum here, and I think you can see my cursor, so I'm just going to make little circles. So this is the sacrum here. This is the base of the spine that your spine sits on top of. We have the tailbone or the coccyx right here. And we have our sit bones, also called our ischia, down here. The reason why we're showing this is part of Webster technique is going to deal with balancing the sacrum here Sometimes this can get rotated, tilted to one side or the other. When things in the pelvis are rotated or tight, it can put some constraint on the uterus. And when the uterus is a little torqued in the body, it decreases the space that baby has to move around. And if it doesn't have the ability to move completely, it's getting stuck on something or something's blocking the way. It has a difficult time getting into that optimal fetal position, which we're going to talk more about what that is in a second here. I also want to highlight this ligament right here, the sacrotuberous ligament that connects your sacrum to your sit bone here. This is one that we also address in Webster technique. Sometimes this can get a little tight and we want to work to release that to help balance that pelvis there. So just want to give it a nice picture and get people familiar with what these inner structures look like, and so you can really see what we are working on when we have you in the treatment room. All right, this is an inside view of the musculature that kind of surrounds, if you can picture the pregnant uterus in here. What I really want to bring attention towards is this muscle called the psoas right here. It's a big, big muscle. It's your primary hip flexor, so it's the way you're able to kind of raise your leg. It connects to all 5 lumbar vertebrae, so in your low back here. And so when this muscle gets tight, it again can put some constraint on the uterus. You can see how you could imagine how the uterus would kind of bump up right next to this muscle here. And so if it's tight and angry, it can kind of get in the way. Let's say a baby's trying to turn and become head down. If they're breached, they kind of run into this here. You can see how that would be a little bit of a roadblock. Another muscle that we tend to work on in pregnancy when balancing the pelvis is this piriformis muscle right here. So that's one of our muscles in the glute, and it is responsible for hip external rotation, so bringing the leg out. And this one can get particularly tight too, and you can kind of envision how this one can get in the way of baby as well when they're trying to head down. So those are the muscles that we tend to work on. There is a psoas minor muscle right here that not everybody has. Fun facts. Most people I think don't have this muscle, but there's a few that do. And sometimes this can get tight and feel like a tight cord along the front of the abdomen when we're feeling around. And so we want to work to release that too if we discover that a patient has that structure. So, fun fact.
I think another fun fact is that the piriformis muscle, which is kind of deep in the buttock, is when that gets really tight, many people, pregnant or not, will experience symptoms of sciatica. So if you're having any pain that's radiating down the leg, the sciatic nerve typically it comes out of these holes. You know, the nerves come out and they either go through the muscle, and some people it goes right through the belly of the muscle. So you can imagine if that muscle gets really tight, it can pinch and choke the sciatic nerve. For most people, it'll go under the piriformis muscle. So a lot of times if someone's experiencing sciatica, we're going to work on this muscle as well.
Yeah. All right, this is a side view of the pregnant uterus here. So we have belly button at the front here, and now my mouse is there lagging a little. We have belly button here, and we have the lumbar spine, low back here. We have our sacrum, this bone right here that transitions to the coccyx here. And the purpose of showing this diagram for you all is to really draw attention to these round ligaments. So I have a lot of patients come in who are pregnant and tell me that they don't know where these round ligaments are. They've heard it referenced all the time. They don't know where they are, how to find them, what they do. So you have one on either side of the uterus, and it attaches to your pubic bone, which is in the front, and you can kind of feel that bony structure at the very bottom of the abdomen, near the groin. And this ligament anchors the uterus to the bony pelvis here, provides support. But an interesting thing about these round ligaments here is the only ligament in your body that contains muscular tissue inside of it. And so these can get tight as well, both ligamentously and muscle tightness. And that can be pretty uncomfortable for people at the front here. And you can kind of feel this tightness like a band or rope on either side of the belly when you're feeling around. So that's your round ligament. Part of our work in Webster technique is to hold some pressure on that round ligament and help to release that and relieve that tension. So, anything to add about that?
No.
No? Okay. Great.
That was great.
Okay, so we've referenced this term a lot, but what is the most optimal fetal positioning? And so that is where the baby is left occiput anterior. Well, what does that mean? So the bone at the base of the skull is called your occiput. There you go, right back there. Yeah. And so on this baby here, we have the occiput right here. This is the left side, so this is facing the front of the person, and so this is the left side and this is the right. So this occiput here is the reference point that we use, and it is facing anterior or to the front of mom versus posterior, and it is slightly tipped to the left. And this position is considered the best because the way that the uterus contracts, it goes in an oblique fashion and will actually turn clockwise. And so the uterus, when it's contracting, is actually spinning baby this way a little bit. Mm-hmm. And that helps guide this head further into the birth canal. When the baby is left occiput anterior, the tip of the head and the way that the birth canal and uterus is shaped makes it so that the baby's head is smallest at the diameter of the cervix. It's more comfortable for mom. It's more comfortable for baby. It helps that cervix open up and signals that it's time to give birth, and it comes out the easiest. Does that make sense? Mm-hmm. Okay. Sometimes the stuff is hard to describe. I have pictures in my head and I know, but getting it out in words is difficult. So here's the difference between an anterior. So we talked about left occiput anterior with the prior illustration. And so that's what this is showing here from a side cut view. So we have sacrum here, belly button is here, birth canal is here. We have the tip of baby's head presenting at the cervix here. In comparison to when the occiput is posterior, you see how much wider this is, and it has to get through here. We note that this posterior presentation is generally more painful for mom, and is one of the lay terms used is called back labor. So you have this hard part of the skull rubbing up against the sacrum, which is a bony part of mother with a lot of nerves coming out in that area. And so it's particularly painful, versus we have the soft baby's face rubbing up against this sacrum as they're coming out. So you can imagine this looks a little more difficult to deliver than this position here, right? Anything to add about that?
I had back labor and
Okay.
it was incredibly painful.
Yeah.
And interestingly enough, my infant's skull was was molded in a very strange position when they finally were birthed. And yeah, we had to do a lot of work with a pediatric chiropractic specialist to kind of get the skull bones back into good position, because all of that pressure of the uterus pressing down through here really molded the skull in a very strange position. So that can happen with back labor as well.
Yeah.
All right. Do you have any questions, Margaret?
No, this is really good though. It's really helps a lot.
Awesome.
Cool.
You guys are explaining it really well.
Oh, thank you.
Great.
So I wanted to provide visuals of many different types of ways that baby can be positioned in utero, just to get you guys familiar with what that looks like. Let's say you had just visited your OB and they tell you, oh, baby is LOT. Well, what does that mean? I'm going to teach you what that means. So right here we have our star position, left occiput anterior. Baby's occiput is to the left of mother, facing forward. Right occiput anterior is our second place when it comes to fetal positioning, because you're still not going to be experiencing that back labor with this position. However, the way that the uterus contracts, this baby's got to turn a little bit more and awkwardly to come out, if that makes sense. We have ROT, right occiput transverse, and this just means that the baby is facing directly to the side of the belly instead of diagonal, like these two are. So we have right occiput transverse here. You advance. We have right occiput posterior, so back labor here and here. Okay, this is going to be more uncomfortable for both mother and baby, but baby's still head down, which is great. And then we have LOT, left occiput transverse. This one's okay, just has to move a little bit to get more of that soft face towards the sacrum. So sometimes the term for a baby being head down in utero is called cephalic. So if you've heard that term thrown around, that's what that means. But I also wanted to show the differences and what that looks like when baby's not head down. So we have breech, where baby is head up. And this can present in a couple different ways. Baby's legs can be outstretched kind of up by their ears. I'm not going to try to demonstrate that for you right now. One leg, they could be delivered with one leg coming out first. So they may not be all folded up like this picture demonstrates, but the hallmark of breech presentations, they are head up. They can also be transverse lying, which means they're side lying. And so in both of these positions here, mother's belly may appear very wide and flat. How do you know if your OB or midwife doesn't tell you if your baby's breech? How can you figure out for yourself kind of where baby is lying? So if your baby's head down, like this one is here, you're going to feel big kicks up at the right rib cage here and small flutters at the left lower aspect of your abdomen. Okay. If they're breech, you're going to feel those big kicks down at the right or left of the abdomen and small flutters up top. Or you'll feel kicks all over with no pattern to it. Transverse, you'd feel those big kicks on really one side versus the other instead of the upper or lower corner. And so that's how you can kind of gauge maybe where baby is lying without having any imaging done. Okay. Where do we come in?
So Dr. Michaela and I are both trained in the Webster technique. And so this is a very specific chiropractic analysis and adjustment that is all about balancing the pelvic bones that we discussed, the muscles, and those ligaments. And again, this creates a better environment for the baby to be in a more optimal position for an easier birth for mom and baby.
Baby is, yes.
Just curiosity, is this technique only when someone's pregnant? Can it be used outside of pregnancy? Or is it only with pregnancy?
It can be used outside of pregnancy to balance the pelvis.
Mhm.
Yeah. Many of our patients are looking for more gentle chiropractic techniques. And so I think this is that we with pregnant women, we're not doing as many big high velocity side twisting kind of adjustments. And so these are a more gentle approach to balance the pelvis. Obviously, we aren't going to be able to release the round ligament on someone who's not, more than 20 weeks pregnant. It's just we can't find it. So that would probably be the one thing that I wouldn't do on a patient who wasn't pregnant.
Mm-hmm. Yeah, I agree. I was gonna say that.
Yeah.
Thank you.
Yeah, of course.
Is this where we're going to demonstrate some of the moves, or?
I think we were gonna go through all the slides and
Okay.
then flip the camera.
Okay.
So one thing I wanted to add is baby and your body are both very intelligent and they know what to do, and your body and baby both want baby to be head down. And so when you can kind of balance that pelvis and create space in the abdomen, in the uterus, the baby's going to know that it needs to be head down and is going to be able to do it. We just have to remove any interference or roadblocks that are getting in the way, and this process will happen naturally. So that's what I wanted to add. So that's our goal, is we balance mom's pelvis, then the baby will take care of the rest, right?
Oops.
Right. Another thing that we will do if we find that the baby is not in the most ideal position is, so it's called a sideline release, where we get patient on their side as this picture depicts, and we work on releasing some of those low back muscles like the quadratus lumborum and the psoas from the side. We can kind of get in there and reach that as well to just relieve tension and create more space. We may also instruct on how to do a forward-leaning inversion and shake the apples, which is a midwife technique used to kind of release the ligaments, tissues, fascia. Again, just trying to create more space and encourage baby to turn. That's really what this does.
I think it's really interesting because, when we think chiropractic, we think bones, and it's more than just working with bones. It's working with muscles, it's working with ligaments. So I think, that's just a good thing to kind of keep in mind also, is that it's not just working with bones.
Right.
It's really working with the whole, maybe not the whole pelvis, but a lot of the structures within the pelvis.
Yeah. Yep.
Absolutely.
Yeah.
They're all connected.
Yeah.
Yeah.
So this is the standing sacral release. This kind of looks like, I always feel like it looks like belly dancing. So this can be used during labor as a technique. And, we sort of gently put some pressure downward on the sacrum. Usually I'm sort of lifting up on the front of the mother's like lower abdomen, and then we just sort of let the mom wiggle and relax, and so this is a static image, but you can imagine that this is a much more dynamic movement, kind of like the shaking the apples in the other image. This just feels really good. It helps loosen up the hips. It helps release any torsion in the uterus, and this particular mother loved it.
It also, correct me if I'm wrong, helps activate the parasympathetic nervous system, so your rest and digest I imagine when you're in labor, fight or flight is starting to get ramped up with anticipation of your new arrival. And so helping kind of center and ground and relax is always really important too.
Yeah.
Okay, so when do you come see the chiropractor? You, as soon as you're pregnant, can start to come see the chiropractor. There's no right time or time that you couldn't come see one of us. But we just wanted to highlight particularly some things that we often see with patients that come in to see us during pregnancy. And so SI joint pain, that is the joint where the sacrum attaches to your hip bones. A lot of times that can get rotated or locked up on one side and can be painful. Sciatic pain, Dr. Goldie touched on that a bit. When that piriformis muscle gets tight and puts pressure on that nerve, and you get pain going down the back of the leg, sometimes even to the feet. I mean, some people can get it really bad. That's a great time to come see us and help loosen up those structures surrounding that nerve to take some pressure off. Pubic symphysis pain, that's the joint between the two pubic bones at the front of the pelvis with a cartilage disc in between. This area is highly innervated with nerves and can get particularly painful towards the, I would say, third trimester is usually when we'll see it, and it feels like lightning bolts right at the front there. It's difficult to climb up the stairs, anything that's shearing the pelvis like this, walking, particularly difficult. And so we can work with that too as part of webster technique. We're addressing that pubic symphysis as one of the joints that we work on. Rib pain, maybe your baby is positioned perfectly, but those kicks are jamming you right in the ribs and it really hurts. A lot of people will notice difficulty with taking a deep breath in, is particularly painful. So work on that. It's been happening a lot lately. There's something in the air that's affecting people's ribs recently. We see it a lot. And then low back pain. We talked about how the psoas muscle attaches to all 5 lumbar vertebrae in the low back. And so when that muscle gets tight, it can tug on that low back. Additionally, your center of gravity is changing. And so that's putting more strain on the joints of the low back as your abdomen grows. So those are all great reasons to come see us.
Do you ever see or think it's helpful for even before pregnancy to come and see you guys just to kind of get a layout of what's going on, or like if you're tight in one area, is it also beneficial to come to you before your pregnancy and then even in early pregnancy just to kind of get a layout of the land?
Yeah, I think so. I think it's wonderful to establish care earlier in the pregnancy. So, obviously when a mom calls us and she's 38 weeks and the baby is breech, is difficult to make the changes at that point. Much easier to establish care earlier and have the entire pregnancy proceed with the pelvis in a more balanced position.
It also helps us stay on top of these complaints that may form. We can catch things early. They're not going to increase in severity to a point where a person's immobile and in so much pain. If you are seeing us regularly right from the beginning or pre-pregnancy, we can stay on top of things like that so that you can enjoy this process and not be living with pain.
Yeah, good question. Well, I think we just wanted to briefly, this is kind of the end of our slide deck, but we wanted to show you briefly what that Webster technique looks like, what a treatment looks like. I'm obviously not pregnant, but Dr. Michaela is going to treat me. So I'm going to stop sharing the screen, and then let's just make sure that as long as we're talking, you should be able to see us. The table is here. If you are trying to find some of the bony anatomy that we've been talking about, if you put your hands on your hips, where your fingers are is the front of your pelvis. This is your ASIS. And then if you kind of come down to the front and you can find the pubic bone. So that's the pubic bone, okay? And then across here is the groin. So we'll be working in the front of the abdomen in this area. If you put your hands on your hips again, where your thumbs are, These are your sacroiliac joints.
Right where your
Okay.
back dimples are.
Right where your, yes, where your back dimples are, and then the sacrum right in the middle, kind of like that.
Yeah,
The tailbone down at the bottom.
yeah. Can we do a full screen of our screen just so we can see how that looks while we're working?
I think I
Sure.
pinned you guys on my end anyways.
There, that's easier. We need to kind of see where things are.
Yep.
Okay, let's get started.
Cool.
Okay, so we have these amazing pillows that have a hole, like a hole in them. And so our pregnant patients are able to lie face down and have the belly supported as
Oh, wow, that's cool.
as a woman advances in pregnancy, we can stack them and have a larger belly or more advanced pregnancy. So I'm gonna lay on these.
We get a lot of comments saying, oh, it's so nice. I haven't laid on my stomach in so long. I'm a stomach sleeper and miss this. So it's nice to have.
Yeah.
Yeah. So the first thing that we're going to do with Webster is check which side of the sacrum needs to be adjusted. And so I do this with a leg check here. So I bring Dr. Goldie's legs together and then I push them towards her glutes here, and maybe you can kind of see how this left leg here approximates the glutes closer than this right leg here. So this right side is a little stuck. So we want to adjust the sacrum on this right side. And we do this using a drop adjustment. And so what that means is this table drops up underneath her. I push on the area that needs to move, and then it falls below her, absorbing all of that force. So she's not absorbing the force, and neither is baby. So it falls like that. So I like to do this 3 times at the side of the sacrum here. So we have 1. Oh. Sometimes the tension gets heavy with the table. 2. And the second structure that we work on is that piriformis muscle that we had previously discussed. And so what I do here is I just like to check both sides for any tenderness, tightness. And the way that we release that is I put some pressure on it here with one hand. I bring the leg up like this. And then we bring that foot in towards the midline and really stretch that muscle. This is one of those it hurts so good movements. My left side gets particularly tight in general.
I'm like, oh, Goldie, you must be getting some nice relief.
It's not terrible. It's definitely
Beautiful, but
sucks to have my job today.
I'm gonna go ahead and do the other side really quick. And Dr. Goldie's right side is tighter, as you could imagine. I have to actually
So you really pick up on the tension between the two different sides, or when there's more tension in an area, you definitely feel it.
Yes. I feel it, they'll feel it, we'll both feel it.
Gotcha.
The third thing that we address while the patient is laying face down is the sacrotuberous ligament, which I talked about attaches your sacrum to your sit bone. This can get particularly tight and kind of torque the pelvis. So we want to just contact that ligament. I'm going to use my thumb and just hold it like 30 seconds and let it relax under that pressure is really all it needs. So I'm going to find it here and we're just going to hold it. This is a little hard to see for you guys, I know. But you can kind of picture if you drew a line between your sacrum and your sit bone and connected them, that's where I'm contacting right now. And just hold it. All right.
And what is that ligament again, or that area?
The
called?
sacrotuberous ligament.
Okay.
Yeah. All right. Then we have our awesome patient rise up. We scoop the pillow away. And then we move on to the front here. And so we want to address the pubic bones in the front here. So we feel, and I'm checking to see which bone is more prominent. So I feel it closer to the ceiling in comparison to the other side. And so I need to adjust Dr. Goldie's on both sides, but that's generally what I'm looking for. And I use the activator for this because it's gentle. That's a very sensitive area to touch, and so we don't want to be thrusting into there unless we absolutely have to. So we just give her a couple of taps with this. This is an adjusting tool that we use for gentle adjustments. It just provides a little force into that joint space and helps us move those structures nice and easy. It's good for children, elderly patients, or those that just prefer a more gentle approach. Next one we work on is the psoas muscle. And so we have our patient bend our leg here. We find that front of the hip, that ASIS Dr. Goldie went over, and I'm going to roll inwards in between the pregnant uterus and that bone there. And we're going to contact that muscle and release it. I have my patient slowly straighten their leg to stretch that muscle. Yeah, this is another hurts so good. And we do that 3 times on each side. There we go. Good job. One more.
Oh, that is really tender today.
Great. Well, I'll spare you the other side.
For now.
We'll work on it later. Last one I'm going to work on is releasing that round ligament. So I just feel kind of where they attach at the pubic bone here, and then we just hold some pressure on it, just like we did for the sacrotuberous ligament. And that's Webster.
Yeah.
Oh,
Now we also wanted to go. Do we want to go over sidewise, or should we not lose anything like that? No,
That's good for now.
okay.
Yeah. Yeah, so
Uh,
that's what the Webster technique looks like in action, and the anatomy and what it looks like to get a treatment.
oh, cool. I
Yeah.
think one of the things that we get, I mean, I know optimum is LOA position, but I think it almost if we hear that, if a pregnant woman doesn't hear that that's ideal position, we can kind of sometimes, I would think, get like apprehensive and scared and everything. And I think we just, and you said it really well, both of you, in different ways, said that, baby and the mom's body know how to get things into the right position and how to really correct that situation. And so even though you might get that, oh, you're not in the optimal position, it's not ideal not to be in the optimal position, but also it's not something that it's something we have to work on, but it's not something we necessarily have to fear, because that's not going to help you out anyways.
Yeah.
Yeah, we have solutions.
Yay.
Yeah. Just trust your body.
Yeah.
And we'll just help facilitate that. And it's really amazing to see results from this. I had one pregnant patient who was breech presenting, and I worked with her with the Webster technique once, and she came back the next week and had joyfully told me a baby had turned. So it's
wow.
Yeah.
That's exciting.
So sometimes they will turn really fast after we do this type of work. Sometimes it takes a couple visits, and rarely it doesn't happen at all for whatever reason. So just like to make sure that people are managing expectations. But we generally see quite a bit of change after doing this technique. So it's really exciting.
And do you see women postpartum?
Yes.
Yeah.
Mm-hmm. Really important.
And is there like a time limit or a window? Like, is it like something that should be done right away, or should wait a couple weeks, or is it vary? Or
That's a good question. I think, obviously if the mother had a cesarean section, you'd want to make sure that she was cleared and everything, surgically is healing really well. That would be maybe the one time that, we have to say, make sure you get cleared by your OB.
Mhm.
Although, many of the postpartum women that we see end up with more neck and shoulder pain. So it's from holding the baby, it's from rocking, it's from nursing, it's, breastfeeding. And so at that point, we're mostly managing what we like to call mom shoulders.
That makes sense.
I had a woman come in yesterday. I think she's 10 days postpartum. I didn't adjust her lumbopelvis. We just worked on the neck and shoulders. She just had so much neck pain and tension, and felt a tremendous relief after getting just that area worked on. So
it's amazing how a 6-pound to 8-pound or even bigger holding that for extended amount of time can really get into the neck. And
so we talk with our postpartum mothers about ergonomics and using pillows and getting the right support so that they're not just flexed holding the baby the whole time. And we also treat dads for mom shoulders as well, because some of them are doing a lot of the rocking while mom's recovering.
Yeah. And I know, Michaela, you work with infants. What is your specialty with infants? What are your two things that you really work, or a few things that you work on with infants?
I generally address birth trauma. So if the delivery was traumatic, oftentimes we'll see a lot of tightness at baby's neck and head, and that can really affect them systemically. More irritable, digestion isn't great, different things like that. So I like to address that. I also have a special training in detecting ties. So I look for, I analyze the breastfeeding, and I check inside the mouth and screen for lip and tongue ties and make an appropriate referral if needed, and kind of troubleshoot breastfeeding things that come up.
Cool. And also, I do know that you also help out with baby's constipation, right?
Yes. Yes.
It's for secret talents. Not so secret.
Yeah, the nerves that come out of the sacrum are very innervated in the gut there. And so sometimes a little gentle adjustment with the activator to the sacrum can have really great explosive results.
All right.
Yeah.
Wow. Well, I just want to thank you both and your practice for all the work you guys do for pregnancy and for mama and for baby. It's really I think it's a special gift and a special I don't know how to call it, but anyways, I just wanted to really thank you for all your work you've done with pregnant moms and babies, and for also just coming and sharing your practice and your experience here and with the Home Birth Cafe audience. And thank you so much. And definitely, you're definitely a asset to Aptos on a cruise area.
Thank you so much, Margaret. And it was such an honor to be able to speak for your group today. I know we've been looking forward to it for many months now. This has been in the works, so I'm so happy to.
Yeah. Thank you, Margaret.
Thank you so much, both. I'll stop there.